teacher and everyone. I am from group number 7. Before we begin, I have a small question for you. During the recent flu season, how many of you took a Panadol or Efferalgan when you had a headache or a fever? I believe most of you did. Paracetamol, also known as acetaminophen, is so common that we treat it like a household item, just like bandages or saline. We use it for teething babies, for adults with muscle pain, and for the elderly with joint pain. Our topic is adverse drug reactions of paracetamol. My team consists of 5 members. Our presentation is divided into 5 parts. First, let's look at what paracetamol really is. Intravenously, it's an acetylene-P-aminophenol. It's one of the most effective drugs for pain and fever today. What makes it different? It's not an NSAID like aspirin or ibuprofen. This means it's safer for stomach and does not affect platelet aggregation. Because it's a very safe therapeutic tool, the World Health Organization lists it as an essential medicine and the first choice for pain and fever treatment. However, Paracelsus, the father of toxicology, has once said, the dose makes the poison. This is true for paracetamol. When you take a pill, the real battlefield is the liver. At a normal dose like 500 mg, the liver safely processes 90% of the drug. But the problem lies in mechanisms of how this small amount can become toxic. The scary thing is that the line between a safe dose and a toxic dose is very thin. Also, paracetamol is in hundreds of different brand names, cold medicine, cold syrup, etc. Patients often take 2 or 3 different medicines without knowing they own contain paracetamol. They are overdosing by accident. So, understanding its side effects is life-saving knowledge for both healthcare workers and community. Let's look at the detail in the next slide.
Paracetamol is a very common painkiller and fever reducer. It is usually safe, but besides liver toxicity, it can also cause side effects in other organs, especially when used in high dose or for a long time. This organ include the kidneys, skin, breast, lungs, and stomach. In the kidneys, paracetamol can be changed into a toxic substance called NAPQI. Normally, this substance is moved by glutathione. When glutathione is low, NAPQI damages kidney cells, especially in the renal tubules. Kidney damage can happen even if the liver is not badly damaged. Kidney injury happens in about 1 to 2% of overdose cases. Patients may have less urine, higher creatinine level, swelling protein in urine. Paracetamol can cause rare but very serious skin reactions. This includes Stevens-Johnson syndrome, toxic epidermal necrolysis, and AGEP. In 2013, the FDA warned about this reaction. They do not depend on dose and are allergic reactions. Very rarely, paracetamol can cause low platelets, low white blood cell, or hemolytic anemia. Hemolytic anemia is more common in people with CCDP deficiency. Regular use of paracetamol may worsen asthma in some people. Several allergic reactions like anaphylaxis are very rare. Paracetamol is gentle of stomach giant and safe, but high dose or long-term use may still cause nausea or mild stomach bleeding. In conclusion, paracetamol is common and usually safe, but it can cause various side effects outside the liver. Therefore, it should be used carefully.
Next, I will talk about the hepatocyte. This is the most serious adverse drug reaction associated with paracetamol, causes mainly due to acute overdose or chronic high-dose use. Clinical manifestation is marked by development of liver enzyme, particularly ALT and ALT. Consequently, it may be related to acute liver failure or threatening condition. This slide is about hepatic metabolism of paracetamol. This diagram illustrates the hepatic metabolism of paracetamol and explains the mechanism of liver to toxicity in overdose. After entering in the body, paracetamol is mainly metabolized in the liver through three pathways. Approximately 90% of paracetamol undergoes glucuronidation and sulfatation, producing non-toxic metabolites are excreted in the urine. About 2% of paracetamol is created unchanged by the kidneys. A small fraction, about 5 to 9%, is metabolized by the cytosol P450 system, mainly CYP2E1, forming NAPQI, a high litosis metabolite to hepatocytes. Under normal glycation, NAPQI is detoxified by conjugation with glutathione and severely eliminated. In paracetamol overdose, several metabolic pathways become saturated, leading to increased NAPQI formation and depletion of glutathione. Accumulated NAPQI causes hepatocyte injury and necrosis, resulting in acute liver toxicity. Early start greater the first 24 hours, non-specific system. Early overloaded, nausea, vomiting, and stomach, fatigue, and nausea. More severe stand after 24 to 72 hours. Clear sign of hepatic failure and systemic complication. Jaundice, coagulopathy, and hepatic encephalopathy and acute renal failure.
Factors that increase the risk of slight damage increase in people who are managers, have chronic alcoholism, or are taking medication that increase like enzyme activity such as phenytoin, rifampicin. They factor release glutathione results, making it impossible for the liver to neutralize NAPQI. Combination of the test history and clinical manifestation, the first test from nausea and vomiting to acute liver failure. These tests include quantifying blood paracetamol level, like enzyme index, and coagulation disorder. The key tool is the Rumas Martel chart to determine the result for treatment. If activated cholesterol in the first 1 to 2 hours after taking it to prevent the drug from being absorbed into the bloodstream. Specific treatment and acetylcysteine is the first priority antidote and has regenerate glutathione to neutralize NAPQI. Achieving optimal effectiveness is within the first 8 hours. This complication of kidney failure, blood clotting disorder, and closely monitor consciousness in case of fulminant life failure is necessary to consider the indication for emergency life transplantation based on the criteria for life transplantation.
Rational use of paracetamol. Safe dosing guidelines. Adults mark 4 grams per day or for 1 gram table. Children's dose calculated by weight, 10-15 milligram kilograms every 4 to 6 hours. Key recommendations: avoid the simulated use of multiple paracetamols containing products. Individualized dosing in high-risk patients. Use term therapy. Patients counseling and monitoring. First, provide clear instructions on correct use and dosing intervals. Once about overdose risk with prolonged use or high dose, emphasize potential hepatotoxicity events at therapeutic dose. Educate patients on early signs of liver toxicity, reviews medication history, and monitoring reports ADRS. Future directions: drug development. Develop control release formulation to improve safety, reduce peak plasma concentration of paracetamol, research safer and resist with less hepatic metabolism device, minimize formation of the toxic metabolite NAPQI. Pharmacovigilance and digital technologies. 1. Strengthen post-marketing ADR surveillance systems to enable early detection of rare or serious adverse events. Regularly update the rest safety and usage guidelines. Apply digital tools that alert and prescribing support systems. Conclusions: 1. Paracetamol is widely used, effective, and low cost. 2. Safe as recommended, but dangerous if misused. 3. Most serious adverse drug reactions, hepatotoxicity. 4. Understanding pharmacokinetics and risk factors improve ideas, prevention, and medicine. These are the references used by our groups. Below is our group's presentation. Thank you, teacher and classmates, for listening.